Welcome. I am absolutely thrilled you're here. Today's explainer is really a premium, science-backed masterclass on cardiovascular optimization. Specifically, we're zeroing in on a condition known as dyslipidemia. We are going to decode the clinical blueprint for optimizing your cholesterol, and we're using the Arbor Vitality clinical framework to do it. So if you want a structured, no-nonsense path to understanding your lipid panel and actually improving your health span, you are exactly where you need to be.
Okay, let's dive right into this. We're working with three logical pillars today. First, think, the science of lipids. Second, test, diagnostics and targets. And third, optimize, interventions and protocols.
Let's kick things off with Section 1. Think, the science of lipids. Because we really need to understand the biological mechanisms before we can actually optimize them, right?
So let's start with a clear definition. Dyslipidemia simply means abnormal levels of blood lipids. Clinically, this usually looks like high LDL, reduced HDL, and elevated triglycerides. Now listen, we're not here to fearmonger, but we absolutely have to respect these numbers. Why? Well, because these elevated lipids are heavily, directly associated with driving major vascular and cardiac risks. We're talking about direct contributors to atherosclerosis, strokes, and heart attacks. Now, what's really interesting about this is that our lipids actually come from two completely distinct pathways. First, we have the exogenous pathway. This is basically the dietary fats you consume. You eat them, and they're broken down right in your gut into triglycerides and then transported out to your tissues. But then we have the endogenous pathway. This is an internal process. Your liver actually produces a carrier called VLDL, or very low-density lipoprotein. Think of VLDL as this massive biological cargo ship, manufactured right there in the liver just to transport fats out to your tissues. So the big takeaway here? It's not just about what you eat, it is very much about what your liver manufactures too.
Okay, let's trace the biological detective story of atherosclerosis, because this is the primary outcome we desperately want to avoid. It all starts with endothelial injury. This is essentially a tiny microtrauma to your blood vessel lining, often caused by things like smoking, high blood pressure, or oxidative distress. This little injury, it creates a microscopic opening that allows LDL to penetrate the vessel wall. Once it gets inside, that LDL oxidizes. This triggers an alarm, an immune reaction, where your macrophages, which are basically your immune system's cellular cleanup crew, rush in and try to clear it out. But this creates foam cells, which then form fatty streaks. Eventually, your body builds a fibrous cap over it to try and protect the damaged area. The ultimate danger, the real catastrophic event, happens if that plaque continues to grow under stress and eventually ruptures, because that releases molecules right into the bloodstream that can form a highly dangerous clot.
Moving right along to Section 2, Test, Diagnostics and Biomarker Targets. Precision optimization requires identifying the exact systemic causes.
We always have to take a systems biology approach here, guys, because dyslipidemia isn't always just a simple diet problem. Think about secondary causes we need to screen for. For instance, is there underlying diabetes? We'd want to check HbA1c to look at your long-term blood sugar along with your fasting insulin. Or maybe there's a metabolic slowdown causing your body to just stockpile lipids. In that case, we'd look at TSH and T4 to evaluate thyroid function. We also absolutely need to rule out chronic kidney and liver diseases. And, really importantly, we have to audit current medications. A lot of people don't realize that things like corticosteroids, beta blockers, and antipsychotics can actually drive chronic lipid elevation.
And of course, we need to be on high alert for genetic factors, primarily familial hypercholesterolemia. This is an autosomal dominant disorder. That just means you only need to inherit it from one parent, and it severely impairs your body's ability to excrete LDL, causing it to just build up heavily in the system. This is a massive red flag if you see a younger person, say someone in their 20s or 30s, presenting with arterial disease, unexplained chest pain, or even physical signs like xanthomas, which are little lipid deposits right under the skin. If that happens, immediate screening is absolutely crucial.
So what numbers are we actually aiming for? Here is your clinical biomarker dashboard. Generally speaking, the optimal targets are total cholesterol under 5 millimoles per liter, LDL under 3, and HDL, that's the protective cholesterol, above 1. But I want to be super clear here. Look at this as a baseline, not some rigid universal rule. These targets have to be highly individualized. To put that into perspective, if a patient has pre-existing cardiovascular risk factors, an LDL of 3 might actually still be way too high for them. We might need to aggressively drive it down further on a strict case-by-case basis. Which leads us perfectly into Section 3, Optimize, Interventions, and Protocols. Let's talk about how we translate all this data into actual action. Get this. Achieving just a 5 to 10% reduction in body weight, so we're talking roughly 10 to 20 pounds for a 200-pound person, yields a massive, statistically significant improvement across your entire lipid panel. It is literally a game changer. This foundational lifestyle habit is primarily driven by resistance training, moderate to high-intensity cardio, and, you guessed it, heavily limiting processed foods.
Now, when we look at targeted nutritional supplements, the data is really compelling. Just 5 to 10 grams of psyllium husk daily can yield a 5 to 10% reduction in LDL. Plant sterols at a simple 2-gram dose can reduce LDL by 8 to 15%, and 2 to 4 grams of omega-3s can significantly drop your triglycerides. What's super fascinating here is the mechanism itself. Fibers, like the beta-glucans you find in oats, act like a biological sponge in your gut. They literally bind to cholesterol right there in your digestive tract, actively helping to drag it out and remove it from your body.
But I want to ask you something important. What happens when you've dialed in the diet? You're crushing your workouts, you're taking your fiber, and yet your numbers are still sitting right in the danger zone. Well, when lifestyle isn't enough, what exactly is our next move?
This brings us to our first-line pharmacological therapies, statins. Now, the crucial point is how they actually work. Statins inhibit an enzyme called HMG-CoA reductase. You can think of it as basically hitting the off switch in your liver's cholesterol factory. It stops it from producing so much cholesterol while simultaneously increasing the receptors that clear LDL out of your circulation. We have a few options here. Simvastatin is an older one, usually used if it's the only option available. Atorvastatin is heavily favored these days because it tends to have the fewest side effects. And rosuvastatin is the absolute most potent for lowering cholesterol. Though it's worth noting, as we climb this ladder of potency, we really do have to carefully monitor for unwanted side effects.
And speaking of side effects, here is a really sophisticated clinical pro tip for you. Statins can sometimes decrease the amount of ubiquinol in your body, which is absolutely crucial for cellular energy in your muscles. This drop in energy, that is exactly what leads to the myalgia and joint pain that some patients complain about. If that happens, supplementing with synthetic CoQ10, coenzyme Q10, can be an incredibly effective way to manage these side effects. It helps improve medication tolerance without sacrificing any of those vital cardiovascular benefits.
Okay, but what if statins alone still aren't hitting the target? That is when we step up to advanced longevity therapeutics. Ezetimibe works a bit differently. A 10 milligram daily dose blocks the absorption of cholesterol right in your intestines. Then we have PCSK9 inhibitors, like evolocumab. These are injected just twice weekly or monthly, and they work by preventing the degradation of your LDL receptors. Essentially, it stops your body from throwing away its own LDL recycling bins, which keeps your natural clearance system running at absolute maximum capacity. It is brilliant science.
Rounding out the medical arsenal, we have a few highly specialized alternative tools. Bempedoic acid is a fantastic daily option at 180 milligrams for patients who have severe, unmanageable statin allergies or intolerance. And fibrates, like fenofibrate, are deployed explicitly when hypertriglyceridemia, so excessively high triglycerides, is the primary issue. The main thing to remember here? Every little bit counts. Even a minor LDL reduction of just 2 millimoles per liter makes a massive, compounding difference in your long-term risk profile.
To wrap up this explainer, there is a powerful longevity maxim from the source material when it comes to dangerous lipids. Lower it earlier. Lower it as far as possible. Keep it as low as possible for as long as possible. It is that simple. Please don't wait a year or two to just see what happens. So I'm going to leave you with this final thought. Do you actually know your numbers? And if they aren't optimal, what's your excuse for not taking action today?